molto bene.
All right, thank you. All right, I have no financial disclosures to say. So limbal stem cells are located at the basal layer of the cornea epithelium, and they're responsible to renew the epithelium about every 7 days. When there's a dysfunction of these cells, you get an inability of the cornea to repopulate itself. So limbal stem cell deficiency arises when there's a reduction in the number of stem cells or an inability of the stem cells to function properly. Likely in most patients, it's a combination of the two of these. So in aniridic patients, they're likely born with less stem cells and over time lose more. In chemical injury and Stevens-Johnson syndrome patients, they lose a lot of stem cells at the initial insult, and because of the inflamed environment, the remaining stem cells don't function properly. Conjunctival deficiency arises secondary to inflammation, trauma, and scarring. You lose goblet cells, mucin, glands of Krauss and Wolfram, and tear-forming structures when this arises. Conjunctival scarring can lead to subepithelial fibrosis, foreshortening of the fornices, symblepharon or ankyloblepharon, and surface keratinization. This leads to an environment which worsens limbal stem cell deficiency. So in early limbal stem cell deficiency, we can see loss of the palisades of Vogt, late staining of the epithelium with fluorescein, which you could see very well in the bottom picture, and peripheral corneal neovascularization. Later findings include a hazy irregular epithelium, epithelial defects, ulceration, and even perforation, stromal scarring, and corneal conjunctivalization. So the etiologies of limbal stem cell deficiency can be grouped into congenital, traumatic, toxic, and inflammatory conditions, and I'll go through some of these. Aniridia is the most common cause of congenital limbal stem cell deficiency. It's a spectrum of disease which ranges from total absence of the iris to mild stromal hypoplasia. And it's of note that the variant of aniridic patient can have very subtle findings, subtle iris atrophy, ectropion uvea, correctopia, and coloboma. So a high suspicion needs to be utilized in these patients to manage them correctly. Aniridic keratopathy occurs in 90% of these patients. It starts in the first decade of life, and then it continues over many years to cover the whole cornea. Many of these patients, unfortunately, are still being treated with corneal transplantation with dismal results. Holland et al. Found that young aniridic patients have visual acuity ranging 2100 to 2200, and older patients have a visual acuity around 2400. The progression of visual loss is attributed to this aniridic keratopathy. Patients who achieve a stable ocular surface have a statistically significant improvement of visual acuity. And patients who had a stable ocular surface before stromal scarring ensued did not require a subsequent corneal transplant. So it's recommended that keratolimbal allograft be performed in these patients before stromal scarring arises. Ectodermal dysplasia is another group of over 150 congenital conditions, with at least 3 of them being found to have limbal stem cell deficiency, including EEC, variant of dyshydrotic ectodermal dysplasia, and KID syndrome. Moving on to toxic and traumatic, we'll start with chemical injuries. So in these patients, the amount of limbal damage can be estimated by perilimbal ischemia. However, many of the times, it's just time that'll tell how much limbal stem cells are actually functioning in these patients. They can also get conjunctival deficiency from injury to the conjunctiva, and eyelid abnormalities, which further ocular surface problems through exposure. So once the acute injury is quieted, it's recommended that these eyelid abnormalities be repaired in these patients. Thermal injury, like flame burns and contact burns, are less likely to be associated with limbal stem cell deficiency because of the protective property of the eyelids, and usually the contact burns are small and localized. But if a patient does get significant limbal stem cell deficiency, it was likely a result of an injury where they were sprayed in the eyes with hot liquid. Iatrogenic limbal stem cell deficiency is a group of patients with a chronic progressive epitheliopathy that starts in the periphery and moves centrally. Does not respond to the typical dry eye therapy or cessation of topical medications. And all the patients with this condition were found to have had a prior surgery on the superior corneal scleral limbus. And they have a limbal stem cell deficiency, which is sectoral in that area. Moving on to the inflammatory conditions, we have Stevens-Johnson syndrome, which is an autoimmune disorder of the skin and mucous membranes. It's triggered by an exposure to either a medication or an infectious agent. There's an acute and a chronic phase. As we mentioned, there's significant stem cell loss during the acute phase, but the chronic phase is what is responsible for the long-term problems and is the reason why these patients have the highest rate of stem cell transplantation failure. Mucous membrane pemphigoid is another systemic disease affecting the mucous membranes. They also get conjunctival scarring secondary to this autoimmune process, and you'll see deposition of immunoglobulins at the basement membrane of the tissue in these patients. So Enrique Sarnicola et al. Looked at a large cohort of limbal stem cell deficiency patients looking at etiology. So there's about 432 patients, 738 eyes, and they found that aniridia had the highest population percentage, of the etiology at 31%, followed by chemical injury at 21%, contact lens wear at 17%, Stevens-Johnson syndrome at 10%, and the other etiologies were all less than 5%. So finally, we could classify ocular surface disease. Based on the left-hand column, you'll see the limbal stem cell loss. So we break it down into less than 50%, which is stage 1. These patients are usually able to repopulate their corneal epithelium, and greater than 50%, which is stage 2. Then going across the top, we look at the state of the conjunctiva. So a normal conjunctiva is stage A, and a previously inflamed conjunctiva, which is now quiet, is stage B, and inflamed conjunctiva being stage C. So as you go through this chart, you could see progression and worsening of limbal stem cell deficiency, with the worst stage being stage 2C, the Stevens-Johnson syndrome, mucous membrane pemphigoid, and recent chemical or thermal injuries. Thank you.
Thank you.